Good morning, Mihiraa. Thank you for coming in today. To start, could you tell us a little about yourself and what are you to specialize in intensive care nursing?
Good morning, and thank you for having me. My journey into nursing began with a deep-seated desire to be at the forefront of patient care during their most vulnerable moments. I qualified as a registered nurse 6 years ago and have spent the last 4 years dedicated to the intensive care unit. What truly draws me to this specialty is the profound intersection of advanced clinical science, meticulous detail, and profound human compassion. I thrive in the dynamic, high-stakes environment where critical thinking and rapid intervention directly impact patient outcomes. I am particularly passionate about the holistic model of care, ensuring that while we manage complex machinery and titrate potent medications, we never lose sight of the person in the bed and their family. I am committed to continuous learning and find immense professional satisfaction in contributing to a multidisciplinary team aimed at guiding patients and their families through the most challenging chapters of their lives.
That holistic approach is crucial. Speaking of challenging situations, describe a time you had to care for a critically ill patient whose family was highly anxious and demanding. How did you manage both the clinical priorities and the family's emotional needs?
I recall a specific situation involving a middle-aged gentleman with severe ARDS on ECMO support. His wife and two adult children were constantly at the bedside, understandably terrified, and they frequently pressed the call bell, asking repetitive questions and questioning every minor adjustment. The situation required a structured approach. I initiated a proactive and scheduled communication strategy. Before my shift began, I would spend 15 minutes with the family, outlining the plan for the day, explaining the goals of each intervention in simple terms, and setting realistic expectations. I acknowledged their fear explicitly, saying, "I can see how incredibly difficult this is for you, and it's completely normal to have so many questions." I also enlisted the support of our unit's social worker to provide them with additional emotional support. By providing consistent, transparent information and validating their emotions, their anxiety noticeably decreased. They began to trust the process, which transformed their demands into collaborative communication, allowing me to focus more efficiently on the complex clinical demands of their loved one's care.
That demonstrates excellent communication skills. In the ICU, protocols are vital, but so is critical thinking. Can you give an example of a time you had to deviate from a standard protocol based on your clinical judgment?
Certainly. I was caring for a post-cardiac surgery patient whose protocol dictated a specific vasopressor weaning schedule based on predefined map targets. However, I noticed a subtle but consistent trend. His urine output was declining, and his lactate levels had a slight upward creep, even though his map was within the acceptable range. The protocol said to continue weaning, but my assessment pointed to hypoperfusion. I immediately paused the weaning process. I systematically gathered more data. I performed a passive leg raise test, which transiently improved his blood pressure, and a focused ultrasound assessment showed a small, hypercontractile ventricle. This suggested he was actually volume depleted and dependent on the vasopressor for afterload support, not a primary pump failure. I presented my findings and rationale to the intensivist, recommending a fluid challenge rather than continuing the vasopressor wean. The physician agreed. We administered fluid, which improved his perfusion parameters, and we were then able to wean the vasopressor more successfully later. This reinforced that protocols are guidelines, but vigilant nursing assessment is irreplaceable.
Your vigilance is clear. Now, describe the most clinically complex patient you have ever managed and what made their care so challenging.
The most complex patient was a young woman with necrotizing fasciitis and septic shock post-multiple surgical debridements on CRRT, mechanical ventilation, and multiple vasoactive infusions. The complexity was multifactorial. Physiologically, she was in a perpetual state of flux. Managing her fluid balance with CRRT while supporting her blood pressure was a constant tightrope walk. Pharmacologically, her antibiotic dosing needed constant adjustment due to the CRRT. From a systems perspective, She had multiple high-risk lines and drains, a massive open abdominal wound with a VAC dressing, and was at extreme risk for every ICU-acquired complication. What made it particularly challenging was her underlying frailty and the psychological toll on the family. Coordinating care required me to be the central hub, integrating inputs from nephrology, infectious disease, the surgical team, and nutrition. It was a 12-hour exercise in extreme prioritization, anticipating complications before they arose, and ensuring every action, from turning to sedation holidays, was perfectly synchronized to give her the best chance of survival.
Managing such complexity requires a strong team. Tell me about a time you had a disagreement with a physician regarding a patient's care plan. How did you handle it?
I advocated for a patient with a traumatic brain injury whose ICPs were trending upward. The covering resident was hesitant to increase sedation, concerned about dropping the patient's blood pressure. I used the situation, background, assessment, recommendation, SBAR technique to structure my communication. I stated the situation. Dara Smith, I'm calling about Mr. Jones, whose ICP has been between 22 and 25 for the last 30 minutes despite current measures. I provided the background. He has a GCS of 5, and we are maintaining his CPP above 60. I gave my assessment. I am concerned we are losing the ability to control his ICP, which increases the risk of secondary brain injury. His BP is stable on a low-dose vasopressor, so I believe we have some hemodynamic reserve. I then offered a clear recommendation. I recommend we trial a small bolus of propofol and titrate it slowly while I closely monitor his BP, and we can have a bag of fluid ready if needed. By presenting a logical, data-driven case with a monitored plan, the physician agreed. We implemented the change, the ICPs came down, and his blood pressure remained stable.
Excellent use of SBR. How do you ensure patient safety during high-stress situations, such as a rapid response or a code blue?
In high-stress situations, I rely on a foundation of drilled protocols and clear role delineation. My primary focus is on maintaining situational awareness and performing my assigned role with precision, whether that is as the first responder, the medication nurse, or the recorder. For instance, as the medication nurse during a code, my process is methodical. I ensure all medications are drawn up correctly with labels, and I verbally confirm the drug and dose with the team leader before administration to avoid any error. I simultaneously maintain a mental timeline for drug intervals, like adrenaline, and voice this aloud to the team. I am also constantly scanning the environment for potential safety hazards, an unsecured airway, a disconnected line, or team fatigue. I believe a safe code is a quiet code where communication is clear and tasks are executed without panic. After the event, I participate in the debrief to identify any system or process issues that could be improved for future instances.
Prevention is key. What specific strategies do you employ to prevent ventilator-associated pneumonia, VAP, and central line-associated bloodstream infections, CLABSI, in your practice?
Preventing HAIs is a non-negotiable part of my daily practice, and I approach it through a rigid, bundle-focused mindset combined with constant vigilance. For VAP prevention, I am fanatical about maintaining the head of bed at 30 to 45 degrees unless absolutely contraindicated. I ensure daily sedation holidays and spontaneous breathing trials to reduce ventilator days. Meticulous oral care with chlorhexidine is performed every 4 to 6 hours, and I am diligent about subglottic suctioning. For CLABSI prevention, my practice is anchored in absolute aseptic technique during any manipulation of the line. I conduct a daily line round with myself, critically assessing the continued necessity of every central line. I scrutinize the insertion site with every shift assessment for the earliest signs of inflammation. I also empower my colleagues and juniors, fostering a culture where anyone can question a break in technique without fear of reprisal. I view these not as tasks, but as fundamental components of preserving my patient's life from iatrogenic harm.
How do you handle the emotional and psychological burden of losing a patient, especially after a long and difficult fight?
The loss of a patient, particularly when you have fought for over many shifts, is a profound and heavy experience. I process it through a combination of professional reflection and personal compartmentalization. Immediately after the event, I focus on providing dignified and compassionate postmortem care, which serves as a final act of respect for the patient and a ritual of closure for me. I then make it a point to engage in a formal or informal debriefing with the team, which is cathartic and allows us to share the emotional load and support one another. I consciously reflect on the case, acknowledging that we provided exemplary, evidence-based care, but that some pathologies are beyond the reach of modern medicine. This helps mitigate feelings of personal failure. Outside of work, I maintain strict boundaries. I exercise regularly and spend quality time with my family to decompress. Acknowledging the grief without letting it consume me is essential to maintaining my longevity and compassion in this demanding field.
Describe your experience with an approach to managing a patient on therapeutic hypothermia, TTM, after cardiac arrest.
Managing a patient on TTM is a highly protocolized and nuanced process requiring extreme attention to detail. My experience involves managing all phases: induction, maintenance, and rewarming. During induction, I work rapidly to initiate cooling, often with chilled fluids and a surface or intravascular cooling device, while closely monitoring for complications like shivering. The maintenance phase is where meticulous nursing is paramount. I continuously monitor core temperature, using specialized probes to ensure it remains within the narrow target range. I am vigilant in managing shivering using a structured tool like the Bedside Shivering Assessment Scale, employing interventions from skin counterwarming to targeted sedation and paralytics. I meticulously manage hemodynamics, as patients are often labile, and adjust vasoactive drips accordingly. The most critical phase is the controlled, slow rewarming, where I raise the temperature by no more than 0.25 to 0.5 degrees Celsius per hour, watching meticulously for complications like rebound hyperthermia, hypotension, or rises in ICP. Throughout, my focus is on preventing secondary brain injury and optimizing neurological outcomes.
How do you ensure effective handover when your shift ends, especially when the patient's condition is unstable?
An effective handover is a critical patient safety intervention, especially in instability. I structure my handovers using the ISBAR format to ensure nothing is missed. I begin by identifying the patient and the situation. This is Mr. Ahmed, a 68-year-old man day 3 post-MI, now in cardiogenic shock. I then provide a concise background covering his admission reason and key comorbidities. The assessment is the core. I present a systems-based summary, but I always start with the most pressing active problems. For instance, his primary issue right now is his tenuous hemodynamics. He's on high-dose norepinephrine, and we're struggling to keep his MAP above 65. I detail what we've tried in the response. My recommendation clearly outlines the ongoing plan and what to watch for. The key for the next shift is to watch his lactate trend and urine output. The intensivist is considering an Impella, so please keep the family updated. I ensure the oncoming nurse and I look at the monitor, the ventilator settings, and the infusion pumps together, creating a shared mental model before I leave the bedside.
Imagine you notice a senior colleague consistently cutting corners, perhaps with hand hygiene or aseptic technique. How would you address this delicate situation?
This is a challenging but vital scenario for patient safety. A direct public confrontation could be counterproductive. My approach would be graduated and respectful. Initially, I would adopt a collaborative and non-accusatory tone in the moment. For example, if I noticed a missed hand hygiene opportunity, I might say, "Hey, I think the dispenser behind you is free," offering a gentle reminder. If the pattern persisted, I would seek a private moment to speak with them. I would frame the conversation around our shared commitment to patient safety, using I statements to avoid sounding accusatory. I could say, "I've noticed it's been incredibly busy, and sometimes in the rush, the hand hygiene protocol can be missed. I'm concerned it could pose a risk to our vulnerable patients, and I wanted to check if there's anything I can do to help us both stay on top of it." This approaches it as a shared problem. If this did not affect change, I would be obligated to discuss my concerns with my nurse manager to ensure a systems-level approach to address the behavior, as patient safety must always be the non-negotiable priority.
What is your understanding of the role of family-centered care in the ICU? How do you implement it practically?
My understanding is that family-centered care is a philosophy that recognizes the family as an integral part of the patient's ecosystem and, by extension, the ICU team. They are not visitors but partners in care. I implement this in several practical ways. I begin by establishing a therapeutic relationship from the first meeting, learning their names and their relationship to the patient. I provide structured, consistent updates in layman's terms, ensuring they understand the plan and the rationale. I actively invite their participation in care within safe boundaries. This could be as simple as assisting with mouth care, applying lip balm, or talking to the patient, which I explain is profoundly therapeutic. I am highly attentive to their psychological needs, offering resources like pastoral care or social work. During family conferences, I ensure their voice is heard and their questions are answered. By empowering the family, I reduce their helplessness, which not only supports their coping but also creates a more compassionate and holistic healing environment for the patient.
Describe a time you made a medication error. What was the error? What did you do immediately? And what did you learn from it?
Early in my ICU career, I was administering a scheduled 4 antibiotic. In a moment of distraction during a high-acuity situation, I inadvertently administered a bag of normal saline that was hanging as a keeper for instead of the antibiotic. I realized the error about 20 minutes later when I went to disconnect the line. My immediate actions were guided by patient safety and transparency. I first assessed the patient for any adverse effects. There were none, as it was just saline. I then immediately informed the charge nurse and the attending physician, documenting the event factually in the incident reporting system as per hospital policy. I personally apologized to the patient, even though there was no harm, explaining the mistake. The learning was profound. I realized my system was flawed. I was relying on memory in a chaotic environment. I immediately changed my practice. I now always use a medication scanner where possible, and if not, I physically label the line I am injecting into with the drug name and dose at the Y site. This creates a visual check that has prevented any subsequent errors.
How do you stay current with the latest evidence-based practices in critical care nursing?
I consider lifelong learning a professional and ethical obligation. My approach is multifaceted. I am an active member of professional bodies like the American Association of Critical Care Nurses, AACN, which provides me with access to their publications, such as Critical Care Nurse Journal and their practice alerts. I regularly attend hospital grand rounds and any available workshops or simulation training. Furthermore, I have cultivated a habit of evidence-based inquiry in my daily practice. When I encounter a clinical dilemma or a new practice is introduced on the unit, I take the initiative to search for the latest research and guidelines on platforms like PubMed or the Cochrane Library. I then discuss these findings with my colleagues and educators, fostering a culture of inquiry on the unit. I recently completed a certificate course in critical care electrocardiogram interpretation to sharpen my skills. This continuous engagement ensures my practice is not just based on tradition, but is dynamically aligned with the best available evidence.
You have a patient who is awake, intubated, and clearly frightened. How do you manage their anxiety and facilitate communication?
An awake, intubated patient is in an inherently terrifying situation, and my first priority is to establish trust and restore a sense of control. I immediately ensure they are comfortable from a sedation and analgesia standpoint, collaborating with the team to optimize this. I always explain everything I am doing before I do it in a calm and reassuring tone. I say, "You are in the ICU, you have a breathing tube in, and you cannot talk. That must be very frightening. I am going to take care of you." For communication, I use a multimodal approach. I use a simple communication board with pictures and common phrases. I ask yes/no questions that they can answer with a nod or shake of the head, and I am patient, repeating and clarifying to ensure I understand them correctly. I also involve the family, coaching them on how to communicate and provide reassurance. The goal is to make them feel like an active participant in their care, not just a passive recipient, which is fundamental to reducing anxiety and preventing delirium.
Tell me about a time you took initiative to improve a process or a practice on your unit.
I noticed a recurring issue with the organization and restocking of our difficult airway cart. During several rapid responses, there were moments of delay as team members searched for specific equipment like different-sized laryngoscope blades or bougies. I took the initiative to lead a project to reorganize it. First, I sought permission from my nurse manager and the lead intensivist. Then, I formed a small team with another senior nurse and a respiratory therapist. We audited the contents against the recommended checklist and then designed a new layout based on the sequence of use during an intubation. We color-coded drawers and used labeled, clear bins for small items. I created a new visual checklist and a responsibility roster for checking the cart at the start of every shift. After implementing the new system, I collected feedback from the team over a month. The result was a unanimous report of improved efficiency during emergencies, reducing stress and ensuring vital equipment was instantly accessible. This small project reinforced how frontline nurse-led initiatives can significantly enhance patient safety and team performance.
How do you prioritize your care when you have multiple critically ill patients assigned to you?
Prioritization in the ICU is a dynamic and continuous process that blends Maslow's hierarchy with immediate clinical threat. At the start of my shift, after a thorough handover, I perform a rapid ABC assessment on all my patients to identify any immediate life threats. I then create a mental and often written timeline of time-critical tasks, such as medication administration, lab draws, and turning schedules. I constantly triage needs based on acuity and stability. For example, a stable patient on a weaning protocol may need less immediate attention than a newly admitted septic patient whose vasopressor is titrating every few minutes. I leverage technology, setting alarms appropriately, and I delegate appropriately to nursing assistants or colleagues when possible. Crucially, I maintain open communication with my charge nurse. If one of my patients is deteriorating and consuming all my attention, I proactively signal that my other patient may need assistance. This flexible, systems-thinking approach ensures that all patients receive safe and timely care, even when demands are high.
Describe your experience with end-of-life care and facilitating a good death in the ICU.
Facilitating a dignified, peaceful death is one of the most sacred responsibilities in ICU nursing. My experience involves guiding families through the transition from curative to comfort care. This begins with compassionate, honest communication, often in collaboration with the physician, to ensure the family understands the patient's condition and prognosis. Once the decision for comfort care is made, my focus shifts entirely to the patient's symptom management. I ensure aggressive palliative sedation for air hunger or pain, titrating medications to comfort, not to an arbitrary dose. I create a serene environment, dimming lights, playing soft music if the family wishes, and removing all non-essential lines and monitors. I encourage the family to be present, to touch, and to talk to their loved one. I provide them with privacy and as much time as they need. My role is to be a quiet, supportive presence, ensuring the patient is free of suffering and the family feels supported and without regret, honoring the life that is ending with the same respect we give to one we are trying to save.
This unit deals with a diverse patient population. Can you give an example of how you provided culturally sensitive care to a patient or family?
I cared for an elderly Chinese gentleman who was terminally ill. His family was large and very involved, but they specifically requested that the patient not be informed of his poor prognosis, as it was their cultural norm to protect elders from distressing news. This initially created an ethical tension with our principle of patient autonomy. Instead of imposing our view, I arranged a meeting with the family, an interpreter, and our ethicist. We listened carefully to their perspective and fears. We explained our legal and ethical obligations, but we sought a middle ground. We agreed to frame updates to the patient in a more hopeful, gentle manner, focusing on comfort, while having more detailed discussions with the designated family spokesperson. We also accommodated their request to have certain traditional herbs in the room, not for administration, and allowed more family members at the bedside than typically permitted. By respecting their cultural framework and finding a collaborative solution, we built immense trust, which allowed us to provide effective, compassionate end-of-life care that honored both the patient's dignity and the family's cultural values.
Finally, Mihiraa, why should we hire you for this ICU position? What makes you the right fit for our team?
You should hire me because I am not just a competent ICU nurse. I am a committed team member, a lifelong learner, and a compassionate patient advocate. My 4 years of solid ICU experience have equipped me with the technical proficiency and clinical judgment to manage the most complex patients confidently and safely. However, beyond the skills, I bring a proactive and collaborative spirit. I actively seek to support my colleagues. I communicate clearly and effectively within the multidisciplinary team, and I am always looking for ways to improve unit practices, as demonstrated by my initiative with the airway cart. I have a proven track record of building therapeutic relationships with patients and families during their most traumatic times. I am resilient, reflective, and deeply passionate about critical care nursing. I am seeking a position in a unit that values evidence-based practice and a strong team culture, and I am confident that I can not only meet but exceed the expectations of this role, contributing positively to both patient outcomes and the working environment from day one.